Of course, we will have a discussion on this subsequently. There are a lot of gray areas which we as practicing gastroenterologists also face on a day-to-day basis, especially the relationship of a particular of symptoms in a particular patient of dyspepsia to Helicobacter pylori, the relationship of the symptoms to an identified gallstone. So these are all situations which pose to us very peculiar scenarios for which we need to take individual decisions. But overall, I think your presentation was quite brilliant. We'll now go on to the next presentation, and that is by Venkata Krishna Iyer. Venkat, as he was introduced to us before, quite brilliant. He's won a lot of awards, well decorated, uh, uh, and of course, a person with great future and potential. He's going to be talking to us on the clinical evidence supporting ecoshiamide used in functional dyspepsia and postprandial distress syndrome. As you know, that Dr. Lalit in his last slide mentioned that one of the mainstays of management of patients with dyspepsia is the use of prokinetics. And in India, we are fortunate to have access to almost all the prokinetics that are now available, which means that the basket is big. We need to pick and choose. I really liked one of his slides where he had actually classified patients according to the symptomatology and also given us a hint as to what should be the approach to that particular symptom complex. I think if time permits, we probably go back to that slide later on. But for the time being, I think I'll request Venkat to tell us about the clinical evidence supporting ecoshiamide. I've been using ecoshiamide for quite a long time, and I do find that in particular situations, ecoshiamide is definitely quite useful in patients with functional dyspepsia and postprandial distress syndrome. More from my personal experience later. First, let's listen to Dr. Venkata. Over to you.
So, thank you very much, Dr. Ramesh, for your kind introduction. And after this background setting by Dr. Lalit Chimpi, we are going to talk about the clinical evidence supporting ecoshiamide use in functional dyspepsia and postprandial distress syndrome. Now, in general, what I understood from the previous talk is that the available treatment options for functional dyspepsia is one is H. pylori eradication therapy if it is positive, if the patient is positive for H. pylori, proton pump inhibitors, prokinetics, and tricyclic antidepressants, and other the other group of antidepressants which are available. So these are the major treatment options. Now, I think this has been covered already. Initial PPI therapy, if it is effective, then you continue the PPI. If it is refractory, then you can add a prokinetic to the PPI. So when should you combine a prokinetic and a PPI? Is that if you have reflux, so this is a small slide showing a patient who had reflux symptoms, initial therapy with PPI alone, and then after that prokinetics were added, so the improvement was drastic. And again, in dyspeptic symptoms also, the improvement was drastic after addition of prokinetics. So there are some limitations of available treatment options. PPI are basically effective only in patients who have the epigastric pain type of functional dyspepsia, that is, those who have burning or heartburn in functional dyspepsia. And there were some studies where it was shown that in early phases of clinical trials, mosapride and etopride were not superior to placebo. So where are we now? So there are other treatment options, as it has been said that we have the entire basket of all the prokinetics in India. If we talk about levosulpiride, which is very commonly used, but it has some side effects. prolactin it can increase, galactorrhea can happen. So in females particularly, you will have periods which are going haywire. They may have breast milk secretion, which sometimes even in the unmarried females, it's very distressing. Even in males, when hyperprolactinemia is there, they complain of erectile dysfunction. So always in my male patients, whenever I give levosulpiride, in those limited patients where I give levosulpiride, I always ask them for sexual dysfunction in follow-up. Domperidone has safety issues. It can cause QT prolongation. It can also lead to hyperprolactinemia. Cardiac arrhythmia is again another issue. Although it is said that it does not cross the blood-brain barrier, but the other issues with QT prolongation are present in that. High quality, large scale studies on metoclopramide and domperidone in functional dyspepsia are lacking. There are two other prokinetics which were studied previously. Tegaserod, which was a 5-HT4 agonist, but however, there was a voluntary withdrawal of Tegaserod from India as well. We had that drug, and it was actually written in constipation predominant IBS. Also had effect in patients with functional dyspepsia, but that drug, because of voluntarily being withdrawn by the companies, it is not available in the market. Prucalopride is also effective in patients, but because it's a pan-GI prokinetic, but the data in functional dyspepsia is limited. So after talking about all the other options and their limitations, we have this fairly new drug. Of course, it has been available for the last 2-3 years, but a fairly new drug which is called acoshamide. So it was originally developed and approved in Japan in 2013. It is the world's first approved drug for functional dyspepsia. So it is specific for functional dyspepsia for postprandial fullness, upper abdominal bloating, and early satiety. It's a first in therapeutic class that is anti-functional dyspepsia drug. So that's the only drug which is specific for that indication. The long-term phase 3 trials was completed in the EU, and phase 2 trial has been completed in the US. The mode of action differs from other prokinetic drugs. It enhances the ACH release and reduces the ACH breakdown in the GI neuron synapses. So it has a favorable risk-benefit ratio. It is better efficacious than the other prokinetics, and the safety profile is similar to placebo. There are no affinities to 5-HT2, 5-HT3, and 5-HT4 receptors, and low affinity for D2 receptors also, which are responsible for the extrapyramidal side effects. It has not been shown to cause QTC prolongation or cardiovascular ill effects, and there are no specific clinically significant safety concerns. So what is the mechanism of action? So there are dual mechanism of action. So you see this is the synapse. So it's a neuromuscular junction. At the level of the neuromuscular junction, acetylcholine is the neurotransmitter that acts. So it enhances the release of acetylcholine, and it reduces the reuptake of the acetylcholine. So it enhances from the enteric neurons, more ACH is released, and there is reduced acetylcholine breakdown because of inhibition of presynaptic acetylcholinesterase activity. So more acetylcholine, more time. So it results in enhanced gastric accommodation and enhanced gastric emptying. So we all know this picture where the mechanism of how functional dyspepsia occurs. So there is an impaired fundic relaxation, there is a decreased antral peristalsis and a decreased gastric emptying, and there is a pyloric resistance and a duodenal resistance, and there is incoordination in the antropyloric duodenal complex movements. So this acoshamide is known to improve the impaired accommodation. It propels the antral motility and corrects the gastric emptying, which is delayed, and this helps in improving the functional dyspepsia symptoms. So what is the approved indication? Approved for meal-related functional dyspepsia symptoms such as postprandial distress, epigastric bloating, and early satiety. The adult dose is 100 milligram twice daily before meals. So what are the relevant pharmacokinetics? The T half is 13.3 plus around 7 hours. So for the after administration of single dose of cochiamide, the Cmax is higher if it is administered before meals, and it is predominantly excreted in feces. Only 5.3% is excreted in urine. So even in patients with renal failure, it is safe. There is less potential for drug interactions because it does not affect the CYP system. Because there are a lot of concerns whenever a drug is metabolized to the CYP system, that is a cytochrome P450 system. So now what happens? So this is one study in which there was after administration of acosamide, the expansion of the stomach by ultrasound was checked by after giving a 400 ml injection of a liquid meal. So in placebo it was not able to expand, whereas in acosamide there was significant expansion of the proximal stomach. So there was a significant improvement in the gastric accommodation gastric accommodation, and then thereafter there was also improvement in the emptying of the stomach. There was another study here in Journal of Gastroenterology in September 2016, in which a 2-week gastric scintigraphy study was done for effect of gastrointestinal motility in patients with functional dyspepsia, where you see here that the change at 2 weeks, so gastric accommodation and the gastric emptying. So the yellow one is the placebo and the orange one is the treatment bar. So you can see that significant improvement is there between the after administration of 2 weeks of acosamide. So gastric emptying and gastric accommodation both improve. So this is a representative picture of the scintigraphy. So this is the routine scintigraphy of a patient. If you give acosamide, you can see that there is some increase in radioactivities in upper part of the stomach, so which suggests that gastric accommodation, at least early gastric accommodation, is improved. Now in functional dyspepsia, there are lot of trials which are done in Japan, Europe, and even the short-term and long-term trials. Consistent efficacy was shown in all the trials for safety and efficacy. So this is the elimination of postprandial distress symptoms. So in every study, the 100 mg dose, thrice daily dose, was shown to be eliminating the symptoms of postprandial fullness, upper abdominal bloating, and early satiety. So when we talk about safety, so what is a long-term safety? So there was this study which was conducted, and it was published in Neurogastroenterology and Motility. It was to study the long-term efficacy and safety of acosamide and postprandial distress syndrome, and it was given in 100 mg TDS dose for 1 year. And all the parameters of improvement in functional dyspepsia, quality of life, work productivity, everything was studied, and safety outcomes were also taken into account, and 207 patients were studied. So how the evaluation scores were done? There was an overall treatment efficacy scale. So it was a Likert 7-point Likert scale from ranging from 1, which is severely worsened, to 7, that is strongly improved. So this recording was conducted once in a week. The postprandial distress symptom score was calculated. It's a validated 8-item severity scale in which all these were recorded on a daily basis, and grading of 0 to 4 on a 5-point Likert scale was given, and higher scores indicating greater severity. So quality of life, the SF36 questionnaire was used, and also this short form Nepean Dyspepsia Index was used, SFNDI, and both the scales were recorded on baseline, week 12, 26, 38, and 52. there is another 11-point Likert scale called the work productivity and activity impairment scale. So this was greater scores indicate greater impediment. So the scale was recorded again on baseline, week 12, 26, 38, and 52. So what was the overall treatment efficacy? So you just see here. So as the drug is given, so slowly there is overall treatment efficacy. So you first really need to explain to the patient that you please continue the medicine. If effect of the medicine takes a little time to start. So after 7 to 8 days or 10 days is when you have a proper efficacy of the medicine, and say maybe after 4 weeks you have a good efficacy of the medicine, and after that long term efficacy up till week 52 was maintained in around 50 to 70% of the patients. So this is the change in the from the baseline of the various symptom scores. So that is a function, postprandial fullness, early satiety, and upper abdominal bloating. All of them had reduced by at least 1 to 1.5 times from the baseline in the 52-week treatment period. The quality of life change from the baseline had also improved. And if you see the efficacy, so this orange line indicates absenteeism. Of course, no one remains absent from work just for postprandial distress symptoms. But if you see impairment at work, work productivity loss, and activity impairment, everything they reduced after taking the ecoshamide, and this improvement was consistently there since for 52 weeks. So this major study actually showed that a majority of patients who maintained exposure to ecoshamide for more than 50 weeks, and there were no significant safety concerns, no deaths, no treatment-related severe adverse events, or clinically significant lab test results. The long-term safety trial is the first to demonstrate that ecoshamide can be safely administered for at least a year. There were few side effects which were noted, that is 8.7%, but they were very minor side effects. And the more than 1% what was noted was nausea, abdominal distension, and constipation. So this is noted. Another trial for safety efficacy in Japan. It was open label, 48 weeks, 32 centers, 100 mg TID. And this had actually screening visit, 8-day baseline period, and then 48 weeks treatment, and treatment visit for every 4 weeks. These patients were made to visit and their symptoms were evaluated. Again, here overall treatment improvement rate was good, and it was 26% at week 1 and 60% at week 8, and it was then subsequently maintained. There was elimination of all the 3 cardinal symptoms: postprandial fullness, upper abdominal bloating, early satiety, from week 8 with the study treatment. So it takes a couple of months actually for the drug to completely start acting. And then, so all you need to counsel your patients is that you have to keep a little patience. This drug will slowly but surely act. So there were some patients who stopped because they improved. So this study also noted the cessation rate. So 75% actually improved, and they were able to actually even stop the drug. 54.9% needed to restart the drug. The poor response was seen only in 13.6%, and the remission rate with medications was seen in 38%. So in conclusion, in this study, they noted that symptoms improved from an early stage of treatment with ecoshamide, and the improvement effect was maintained even after a dose interruption. So even if patients interrupted, then also the effect was maintained. Adverse events was 11%, and most of them were very mild, except some increased ALT in one patient. So now, how about India, and how about real world efficacy? So this is a study which was done in India. It's a multi-center study, randomized controlled trial. Sorry, this is not a randomized controlled trial. It's a real world study. So where actual care is being received by patients in clinic, because in real RCTs actually everything is monitored, and there is a lot of strictness in the treatment and the criteria. But however, when we come to many drugs which have been previously shown good in RCTs, in real world scenario they have utterly failed. So a real world study was done for this drug, and in India there were centers from 63 centers were selected, and 314 functional dyspepsia patients were seen. 20 centers in the north, 14 in the west, 9 in the south, and 20 in the east. So male to female ratio was 3 is to 3 is to 2. 60% patients were more than 40 years, whereas 13% were more than 60 years. This was the symptom distribution at baseline. 74% had postprandial fullness, 76 had upper abdominal bloating, 53 had early satiety, epigastric pain was noted in 38%, epigastric burning 35%, constipation 26%, diarrhea and 3%. So what was achieved after treatment? So the patient's perception of symptomatic improvement. So no improvement was occurring only in say 1 to 3% of the patients, slightly improved around 18 to 20%, and significantly improved around 60% was the, and complete relief that was. So if we combine these two, so almost 80% of the patient showed that they had either significant improvement or complete relief from the symptoms. So of these patients who showed complete relief, so postprandial fullness, upper abdominal bloating and early satiety were the ones, and those patients actually after 28 days of treatment, this improved. 22 discontinuations in the treatment of 22 adverse events in the treatment, of which 4 went on to discontinue the treatment because of palpitation, nausea, epigastric pain, and perceived lack of efficacy. So there was complete relief in up to 75 to 80% of the patients, and this there was no significant adverse events. The real world study suggests that use of ecosamide was associated with improvement of meal related functional dyspepsia symptoms and an extremely good safety profile. So there are some other studies. There was some comparison study done from Apollo Hospital, Bhubaneswar. So this was symptoms of FD improving with ecosamide and those with levosulpiride. So the red colored is the drug effect. So if you see the score, the at 0 week, this was the score of the symptoms, and then after that, the postprandial bloating has almost disappeared here in ecosamide, and levosulpiride, of course, there is an improvement, but it is not as marked as the ecosamide. So this was a comparison study. Of course, we all know that levosulpiride has its own problems like galactorrhea, increased prolactin, and also some neurological side effects. So, of course, ecosamide would always be a safer and more efficacious option. The meta-analysis always in this, there are multiple which have been done mostly from Japan, and all of them have the forest plot says that it favors ecosamide rather than placebo. That saying that every of this meta-analysis says that ecosamide is efficacious in postprandial distress. If there was another study in which patients who were on PPI, and those patients were identified who did not improve with after giving PPI for 2 weeks. So 105 patients of functional dyspepsia, they were given only PPI initially, and then 23 of them did not improve. Of these 23, they were started on ecosamide TID, added with ecosamide TID, and this, of the 23 patients, 18 actually showed improvement in symptoms. So this suggests that combination of ecosamide and PPI may be effective in selected functional dyspepsia patients with who do not have sufficient improvement with an initial PPI. So that kind of study is also, add-on study has also been done in Japan. this was an adherence study of therapeutic regimen of ecoshamide. So 79 functional dyspepsia patients were followed up for 1.9 years. At 1 year out of 79, 20 had recurrent dyspepsia. So what were the reasons? So those who had severe dyspepsia before treatment had increased rate of recurrence. So those who were continuously taking acoshamide had decreased rate of recurrence. So even continuously taking acoshamide is safe, as well as it is efficacious in preventing a relapse of the symptoms of functional dyspepsia. So those who continued acoshamide had low recurrence rates. So adherence to the acoshamide is a significant predictor for decreased recurrence. So long-term maintenance therapy of acoshamide is therefore recommended. So in summary, I would like to conclude with the statement that the therapeutic options for functional dyspepsia are limited with proven efficacy in this condition. Acoshamide is the world's first approved treatment for functional dyspepsia diagnosed by Rome 3 criteria. Acoshamide is a novel gastroprokinetic drug which exerts its activity by increasing the acetylcholine at the level of enteric neurons at the neuromuscular junction via inhibition of acetylcholinesterase activity and thereby enhancing gastric emptying and gastric accommodation. The ability to improve subjective symptoms has been evaluated in several clinical studies and real-world data in Japan, US, Europe, and India.
Thank you very much, Dr. Venkat. I think if I have to give around 6 or 7 take-home messages from your presentation, which would make it simple for the physicians attending. You can correct me if I'm wrong, but the first important take-home message would be that whenever there is this problem of postprandial distress syndrome, then I think of acoshamide as one of the options. Am I right?
Yes, correct.
Second, you mentioned that acoshamide actually increases the gastric accommodation as well as increases the gastric emptying, both of them.
Yes, correct.
I would just like to sort of open up my mind and pick your brains on this. Basically, if you imagine the stomach, whenever there is an increased gastric accommodation, which means that there is tendency for the food residue or food to accumulate or to be more accommodated better in the fundus. Would that not have an opposite action on gastric emptying? So how is it that both are achieved by acoshamide?
Yeah, so there are phases. So when initially the food enters from the esophagus into the stomach, so the fundic relaxation occurs initially to accommodate all the food that has come in. Now, once the food that has come, so then there is a coordinated movement between the fundus and the going on to the body and to the antrum. There is, the coordinated motor movements of the stomach. They actually do what we call the grinding of the food and proper mixing of the food. And at a later stage, churning of the food, at a later stage of digestion, it happens so that after the particle size is around 3 mm or 2 mm, then these particles are slowly emptied into the duodenum. So that is in a different phase of the gastric emptying occurs later. Initially, when the food enters, there is accommodation. So both of these are actually improved with acoshamide. So, but at different phases of the journey of the food in the stomach.
So I think with the explanation that you gave, but the bottom line, of course, is that both, that is the gastric accommodation as well as the gastric emptying, are improved. And that is what we want in patients with postprandial distress.
So there are various mechanisms. So the ones who have early satiety are the ones who actually have impaired gastric accommodation. And the ones who have a lot of bloating and distress after food, so these are the ones who are actually having the difficulty in gastric emptying.
Yes. The other point, the next take-home message is that all these trials which you had mentioned with Ecoshimide
Yeah.
have used 100 milligrams 3 times daily.
Yes.
And obviously, you give it half an hour before food or something like that,
Yeah. Along with the PPI,
along with
like
the
what
PPI. We also have a single dose once daily formulation available.
Yeah.
Obviously, when you look at compliance issues, giving a once daily would probably be more a better option.
Yes.
Do we have any evidence to say that this is the once daily option formulation is equivalent to thrice daily option in terms of
There are
efficacy?
no trials, sir. I could not come across any trials which have been done particularly with the once daily option. But I presume, like practically, if we think of the thing, so whenever I start a patient on Ecoshamide, I give them thrice daily. So this drug typically has a period of 1 to 2 months before the complete effect takes over. Once the patient is comfortable, say after 2 months with Ecoshamide, then just to improve the compliance, I practically this is what I do. I am not supported by any trials, but this is what I do. That later on I just shift it to once a day sustained release formulation.
Perfect, perfect. In fact, I thought I also was
It
actually
is
looking
my
around.
practice is not backed by any trial, but this is what I
No,
practically
all
do.
of us do the same thing actually,
Yeah,
because in terms of compliance, long-term compliance, probably once daily is probably a better option than thrice daily. Uh,
definitely.
and definitely in my experience also, I believe and I find that once daily option is not inferior to thrice daily option. So certainly 3 months is the usual time I give the thrice daily option, and then I switch over to once
Yeah,
daily option.
absolutely.
Uh, the fourth take-home message from what you mentioned is that it has been used long term, 1 year, as long as 1 year, probably more than 1 year, and without any significant side effects or also a decrease in its efficacy. Am I right?
Yes.
Okay. And the next take-home message is no interactions,
Yeah, no
which
interactions.
is obviously quite a blessing. Now, when we are talking about interactions, you mentioned about various other prokinetics. Uh, Head-to-head trials between one prokinetic versus another prokinetic would not be very many. You did refer to one which compared uh, uh, levosulfide with
Levosulfirate. Yeah.
the Ecoshimide. But by and large, do you think that the drug interactions with the other prokinetics are clinically relevant, or is it something that has been published? Okay, some evidences are there here and there, and it's sort of blown out of proportion.
Yeah, so I find, sir, that the real world data is, I mean, our practice in the real world, we don't find any significant change in the adverse event profile. Of course, we keep levosulfiride on one side because we know that I avoid it in my elderly patients. I don't give it as a first line in females. So that's a different thing. But otherwise, etopride, cinetepride, I think the drug interaction part actually is exaggerated.
Yes, it is something which I thought the the pharmaceutical companies are playing a lot on these drug
Yeah.
interactions, because to be very frank, this concept of QT prolongation with domperidone. I mean, we have been using domperidone for such a long time. In my experience, I have not had any a single experience with that.
So the
But then,
problem with domperidone, if it is used as a separate tablet, let's say 10 milligram twice a day or thrice a day, that's fine. But the problem is all these combinations which are available with 30 milligram, and I have seen prescriptions of physicians who are giving 30 milligram sustained release domperidone
twice daily.
twice a day. So that's where the problem lies. So if we exceed a certain dose, they give fixed dose combinations, and then they tend to use it twice or thrice. And there are some patients who said that I felt very good, but then the effect wore off. So I took another capsule. So that's where the problem lies. So if we are giving it in a proper dose, I think doesn't matter. But the availability of fixed dose combinations and the misuse and overuse of these combinations will lead to problems.
Prescription without understanding the dose schedule. And the sixth take-home message, if I were to say, is that the effect of acoshamide may take slightly longer, may start taking shape only by about 1 to 2 weeks. That is when you start feeling the benefits of acoshamide. And then for some of the symptoms, it may take as long as 8 weeks also. So we need to be patient with this molecule. Am I right?
Definitely. So whenever I start a patient on acoshamide, I always tell them that, this is going to take a little more time. And you'll have to be a little patient about the side effects. You don't need to. There are some patients who don't even wait for 8 to 10 days. So forget 8 weeks, but they don't wait for 8 to 10 days. Then they come back telling that, no, we are still not better. So, but I think that is where proper counseling and, telling the patients preemptively that, you should wait for the effect of the drug to happen.
Some very interesting questions, Venkat, which have come from the doctors who are attending. And one of them, of course, is that, see, we have been talking about gastric accommodation. Now, this questions Dr. Dhirendra Singh. He has sent in a question that if you're talking about gastric accommodation, how do I know that which are the patients where gastric accommodation is abnormal? Is there any investigative modality?
No, I mean, of course, scintigraphy is one, but again, it's not easily available and it's not practical to do gastric scintigraphy in every patient of functional dyspepsia. So, what I generally get a clue from the symptoms, that if a patient is telling that I eat and then I immediately, when I start, I feel very hungry. When I eat, I get full. So early satiety is actually one very typical
satiety.
symptom. Early satiety is one very typical symptom where the patient is actually having impaired accommodation actually. So these are the class of patients I would say that prefer using acoshamide in such patients.
So, Dr. Dhirendra Singh, I think we, even in gastroenterology practice, the diagnosis of gastric accommodation problem is not based on any investigative modality. It is purely the gut feeling, and that is which the symptom that Dr. Venkat referred to as early satiety. A patient who complains of early satiety.
There is a clinical test which I think is used in research, is the water drink test.
Yeah.
So if the patient can take around, say, 700 ml of water and not feel uncomfortable, then he has a good accommodation. But I don't think all those things are practical.
Most of us would feel a bit uncomfortable when we take 700 ml of water.
Yeah.
So we now go on to the next question, and how can a physician, Dr. Siddharth Pandey has asked, how can a physician differentiate PDS and EPS clinically? So it's basically postprandial distress syndrome and epigastric pain syndrome clinically.
So it is the difference is clinical only. There's no rocket science in that. So it's according, the syndromes have been characterized according to the symptoms itself. So the name itself suggests that if there is more of burning, epigastric burning or epigastric pain, then it is actually an EPS. If there is more of a bloating or early satiety or a postprandial bloating or some symptoms like that, then it is a PDS. Postprandial distress syndrome symptoms. So it's classically based on the symptoms itself. There is no
something that is, when you're taking the history and the first impression that you get, could this patient be having a peptic ulcer? So that ulcer-like symptoms. automatically that becomes an EPS, epigastric
Yes.
pain syndrome.
Yeah.
Whereas all those vague symptoms where there's bloating, fullness, all those things can come into the other group, that is the postprandial distress symptom. We also discussed Dr. Dhirendra Singh's next question is, which is better, acosamide 100 milligrams TID or acosamide 300 sustained
I think
release?
this
I think we
question
did.
has already been answered
Yeah,
with my previous research.
we did. Which scores better in PDS and early satiety, etopride or acosamide? Very sensitive question.
So early
Not to be
satiety.
discussed on Lupin forum. But yes, you can.
No. So early satiety particularly is a symptom of poor accommodation. So once you have poor accommodation, then actually classically acosamide helps a lot. Etopride is it's a prokinetic, so I don't think it has an effect on accommodation. More it has actually a prokinetic action on the gastric emptying.
Good.
So it's a personal choice. I would prefer acosamide in patients with early satiety.
Dr. Kurush has sent in a question. Kurush Kohyar. How long should acosamide be taken for how many weeks? I think that also we did discuss. Venkat did mention that you can use it for many weeks. It has in trials, it has been used for 48 weeks or more. There is really no time limit, and the effect does not wear off with time also. In my practice also, what I do is, if a patient is doing well with acosamide, I start with 3 times daily, maybe after about 3 months, switch over to the once daily formulation and continue that for a long period of time. And maybe after 1 year or so, if the patient is now much better, try and take him off that treatment and then see how he is. What do you
One
say,
of the
Venkat?
trials I mentioned also said that even if there is discontinuation of treatment, the effect persists.
Again, a matter of perspective. We know that acosamide has got all these benefits. We know that there are some situations where it is just bloating, nothing else, no pain, nothing. Would you start these patients only on acosamide first and then wait and see how they do? Or in your practice, do you usually start them on a combination of PPI and acosamide?
A difficult question to answer, but bloating can have other causes as well. So if the patient typically has bloating after food, then it can be because of the stasis, gastric stasis. Bloating also can occur due to small intestinal bacterial overgrowth, which would prompt me to test for it and treat for it, say by giving it like rifaximin or use of probiotics. But I don't think PPIs would be very helpful in only bloating. So I think the prokinetics would help, and in patients where I find that they have SIBO, in those patients rifaximin would help.
Good. Dr. Dinesh Dedia has been listening to you very carefully, and he has come out with a very interesting question. He says that given the fact that acosamide takes some time to act, should we give other prokinetics first, and once the patient is stable, we can then switch over to acosamide for long-term relief?
Yeah, so in actual real practice, I do that. So there are some patients, where I tend to use levosulpiride and etopride initially, and then when they are a little better, then I actually tend to shift them on acosamide. So that does happen. Of course, more so with levosulpiride, because we all know about the long-term side effects of levosulpiride. So we would not like our patients to be, for more than 2 or 3 months on levosulpiride. So I do tell them that this drug can have some side effects. So I am shifting you to another drug which is safer, but you will have to be patient, and it will take some time to act. But I don't combine the prokinetics, so I don't think that is a good idea. But I give other prokinetics first, and then shift them to a safer prokinetic. So that's what I.
There was this talk of combination, but comparison with etopride and all that. Do you really think that etopride is a pan-prokinetic, as has been marketed, has been told to us
Yeah,
earlier?
yeah. Even prucalopride has been marketed as a pan GI prokinetic, but I really feel that prucalopride acts more on the lower GI, whereas the etopride acts more on the upper GI rather than anything else.
And acosciamide is very gastric specific. Am I
Yeah,
right?
it is very gastric specific. It does not have much effects on the small bowel, but it does improve symptoms of the postprandial distress.
Dr. Anil Daksini has sent in this question. I think this is something that is a question that is asked for every molecule. What about its renal and hepatic safety? Can it be
So,
used in patients with renal impairment or liver failure?
so there has not been any dose changes which have been recommended for renal patients or liver patients. So we tend to use them in the same dose. Of course, the renal elimination is only 5%. Most of it is excreted in stools. So of course, when it is excreted in stools, it can be secreted in the intestine, or it can be it would be coming from the bile that is released from the liver. So around 90% of the secretion is from the excretion is from the intestine. So I think it should not be a problem with patients with liver failure or renal failure.
Brilliant. I think the questions from the audience have sort of fizzled. Yeah, one more has come in. Can acosciamide be prescribed for gastroparesis?
Yeah. First of all, to give a diagnosis of gastroparesis itself is very challenging. We all know that there are so many drugs which are available, and now we have G-POEM as well for gastroparesis. But the how to define gastroparesis and how to differentiate it from actually dyspepsia is actually it's really very, very challenging. Electrogastrography has come in, but yeah, I don't think it has come in prime time.
Yeah,
So,
not widely available also.
not
No?
widely
Not at
available,
all.
although, and the interpretation of the EGG itself is a challenge for us. Again, most of us always depend on the scintigraphy for the diagnosis of gastroparesis. So I think that's a field where more and more research is required.
Okay, so I think we have covered up a lot of issues. I don't think dyspepsia is such a vast topic. Actually, as a gastroenterologist, it was always a nightmare for me to prepare for a talk on dyspepsia because it's something which is so vague. But I think today we were able to actually shed some light on some of the core issues in the understanding of dyspepsia, especially the postprandial distress syndromes, and try to understand the role of acosciamide in the management of these particular syndromes. So thank you very much, Venkat.
I
Of
also
course,
feel, sir, that in India we are actually spoiled for choices. So we have a big basket and we have to choose the right therapy for the right patient. And I think the one gastroenterologist who is able to give justice to that is actually successful in practice, because these are the patients who are your bread and butter.
bread and butter. Yes, exactly.